53-year-old lady fell off her bicycle and suffered a type Garden 1 right femoral neck fracture. During reduction, the valgus position of the head was acceptable, but a correction of the 20-degree dorsal tilting was necessary. The time between the accident and the beginning of the operation is less than 4 hours, so we're well within the 6-hour limit. We use the Mackay extension table, and with this type of isolation, the Intensify works outside the sterile area. Before the incision, we simulate the optimal position of the distal screw with a K-wire by moving it over the skin. The skin incision will be placed around the cross point of the K-wire and the skin contour in both views. The skin incision lies about 2 to 5 centimeters distally from the entry point to the bone of the distal screw. This depends on the diameter of the soft tissues. The fascia and the muscle fibers are separated carefully, thus preventing damage to the soft tissues and also preventing blood loss. The protection sleeve with the drill sleeve to the 3.2 mm drill bit is introduced to the bone. When the handle of the aiming device is nearly parallel to the lateral skin surface, the sleeves are approximately at 130 degrees to the bone. In the AP view, we should start drilling within 1 cm of the lower border of the lesser trochanter. In lateral view, we'll look for the axis of the femoral neck. We open the lateral cortex with a 3.2 mm drill bit. After this, we introduce the threaded K-wire with the same diameter. We should stop about 5 mm from the border of the head. The end position is controlled from both directions. Now we introduce the proximal sleeve to the bone, and it is fastened with a screw. Here, we open the lateral cortex, also with the 3.2 mm drill bit, then introduce the second threaded K-wire to the subchondral area. Both in AP and lateral views, we can see the proper position of the K-wires. During manipulation of the distal hole, the proximal K-wire prevents the redislocation of the fracture. After removal of the 3.2 mm drill sleeves, we measure the required length of the screw. It is 115 mm. Drilling with the 7.6 mm step drill bit. In case of severe osteoporotic bone, the drilling on the last 5 to 10 mm is not necessary, as the screw is self-tapping. When the bone material is hard, the use of the tap drill is recommended on the full length of the drill hole, otherwise it is quite enough in the lateral third only. We introduce the chosen neck screw, then control the end position, which is very close, about 3 to 5 mm to the subchondral area. After removing the distal K-wire, we loosen and pull out the aiming device. Now we push the distal sleeve with the 3.2 mm drill sleeve together on the proximal K-wire very close to the lateral cortex. After removal of the 3.2 sleeve, we measure the required length of the proximal femoral neck screw. Drilling with the 7.6 mm step drill, then cutting the tap with the tap drill. Finally, introduction of the proximal neck screw to the subcortical area with the help of the intensifier. When we combine the screws with the support plate, the grip of the screwdriver should stop parallel to the diaphyseal axis. Only in this position can the overlands of the femoral neck screws pass through the plate. Before wound closure, we check the proper position of the fracture and implants. The fascia is closed with one suture, then we close the skin. The patient is mobilized with crutches on the next day.